Welcome everyone to this morning's roundtable on the implications for healthcare of the autumn budget. I'm Lee Peart, editor of Healthcare Management. We are a fortnightly magazine and digital publication focused on supporting integrated healthcare. I'm delighted to be joined by such a stellar lineup for our roundtable this morning. I'll just point everyone out. We have Steve Brine, former Health Minister and co-host of the Health and Politics broadcast Prevention is the New Cure, and Steve is in the Body Warmer, I think there's Steve. We have Shane DeGaris, Group Chief Executive of Barts Health NHS Trust in the white shirt, Richard Kirby in the black jacket, who is Chief Executive of Birmingham Community Healthcare NHS Foundation Trust, and lastly, Sally Gainsbury, Chief Policy Analyst at the Nuffield Trust. Thank you again, everyone, for joining us. Obviously, we had the autumn budget, and much was leaked ahead of the announcement, but we did see £300 million in funding for technology and the promise to launch 120 neighbourhood health centres by 2030. In addition, we saw several public health measures, including extension of the sugar tax levy and upgrading of alcohol and tobacco duty. But just in terms of the main announcements, I wanted to start by just asking your views on the technology aspect of the statement. If I maybe start with you, Shane, just what are your response to the 300 million in funding, and how much you expect to have this in terms of impact on care delivery and outcomes?
Yeah, thanks, Lee, and morning, everyone. I think it's to be welcomed, isn't it? I think, and of course, this is in addition to investment that was previously announced in digital. I think for us, from a sort of a hospital, we run hospitals, so 5 hospitals in East London. We need to understand the detail further, but I mean, I really hope this will help enable expansion of remote monitoring, virtual wards, make it easier for patients to book their own outpatient appointments, scan appointments, accessing their own health records through the app. I guess fundamentally supporting patients to be a better partner in healthcare in a way that perhaps we do with other industries. So I think from our perspective, this is a really welcome announcement and will definitely support kind of the left shift.
That's interesting. Thanks, Shane. Can we go to you now, Richard, as well?
Yeah, and then good morning. And I think our perspective will be very similar to Shane's. I think there's a lot the NHS can do to bring digital data and technology to bear on the kind of delivery of what we're seeking to do, and particularly from our point of view, remote monitoring, virtual wards, access to shared care records. So I guess we'd be hoping a chunk of this is able to be deployed in that way, rather than in other parts of the service, but it's definitely a welcome step.
And I guess in terms of the funding, obviously there are good things that will be able to be done with the technology. How much do you think it'll bear on the actual impact in terms of productivity and the elective care targets? Do you think this will have any impression at all on those? Maybe we can go to you, Sally, on that.
I'm sorry to be boring, but I think it's far too early to tell. So the relationship between technological adoption and productivity isn't necessarily straightforward to predict. It depends very much what new technologies you're adopting. And of course, we need to remember that if you're introducing new technologies into the NHS, there needs to be time for the staff to learn how to use that technology and to change their processes. And that is something that is quite frequently overlooked. And also to appreciate the time lag that there can often be between adopting a new technology, adopting a new process that goes with it, and then seeing any improvement in productivity, if indeed that is what it's intended to bring about. Because sometimes technology, is obviously about being able to make new treatments available, which may not necessarily increase productivity. They might increase output and activity, but not necessarily productivity. So I think we do need to be cautious.
That's great. Thanks, Sally. And Steve, would you like to come in on there?
I mean, I'd probably lean more towards the Gainsbury doctrine than the others. I mean, you're right. It does add £300 million capital funding, which is on top of a lot of money that was put for Digi in the spending review. And the whole point of that is to, exactly as you say, to boost productivity for the analog to digital shift. But that only really works when there's service transformation around it. So what I expect we will see is relatively small targeted rollouts of digital, as opposed to the transformation that they really need in the very, very short term. So you would expect there to be big gains where tech then replaces what is high volume analog admin task, referral handling, record access that staff are sort of doing all the time at the moment. But the large benefits, as Sally says, requires integration, transformation, training, taking the workforce with you. And I suppose I always look at, as a former minister, and when I was in the job, I always look at what's on the risk register for this stuff. So I suppose the fact is that a lot of the people that were in what was NHS Digital, NHS England now, that's being emptied out. You know, you've seen it reported drip over the last few months of people leaving being in those posts. So how much is able to be done in-house versus how much is to be able to outsource to the experts and the professionals? How much political tolerance is there to do that within the government? I think there's a massive question around that. There's no doubt, Lee, that Jim Mackey, I saw him at the Tech UK Health Conference a couple of months ago. I can't believe he actually said this on the record, but he did, so I'll repeat it. If we carry on with the NHS doing what it does, which is person sees physician, physician writes letter, often arrives after appointment, patient goes to physical building for appointment, and then round you go again. His words, the NHS is done. So there's no question that they see this digital transformation and why they keep arguing successfully for more capital funding and more digital transformation funding as the key to achieving not just the 10-year plan, but they see it as the key to saving the NHS. But if they don't get the single patient record in place, you don't have NHS Online, which was the centerpiece of the Prime Minister's conference speech. And if you don't have NHS Online, you don't have a lot of the service transformation that needs to happen. So I think there's major question marks over whether this will be spent well, and I doubt that it will be spent across the service quickly.
That's great. Thanks, Steve. Can I just take that up with you, Shane, just in terms of the digital transformation process, I guess. How is that going at your trust, and in terms of timeline and where you'd like to be?
Yeah, look, I think we're trying to embrace this. I mean, I think Steve rightfully points out the fact that there's a big kind of a big bet here about this is going to magically really help transformation. So we're trying to really get behind this, really trying to get behind, particularly with outpatients, which of course, and a trust like Bart's, that's probably our biggest clinical productivity opportunity. So there's a huge piece of work going on about trying to make it easier for patients, easier for staff, and also trying to really eliminate unnecessary follow-ups, which of course is the kind of bane of the NHS infrastructure as it is, and also lots of patients come that don't need to. So that's where we're kind of focusing our efforts, and we think there's a really sizable opportunity there that actually makes a difference from a business perspective, but also from a patient perspective.
That's great. And yeah, I'd be interested to get your views on that as well, Richard.
Well, I think probably generally community services have some catching up to do in terms of the way we use digital and technology to kind of provide day-to-day care in a different way in people's homes. But it's absolutely part of our plan, and it's something we've been putting a lot of energy and investment into. The relationship with GP systems and the interface with social care systems, of course, for community teams becomes really important. So, whilst we talk a lot about a kind of shared care record, it needs to cover the full health and social care spectrum if our teams are going to be able to get the best out of it.
That's great. I appreciate, obviously, we could probably spend half an hour talking on this, but has anyone else got anything to add on this before we move on, or? Sure, yeah, let's go into the neighbourhood health announcement. As the Chancellor confirmed, the plans are to deliver 120 neighbourhood health centres by 2030. I just wanted to get your thoughts on how deliverable you think this will be. If we could maybe start with you, Sally, on that one.
Yeah, thank you. So there's two aspects to this. One is the actual delivery of the buildings, and so they've made a pledge to, is it 120 new centres, and the other is actually the shifting, the increase in resources, the sort of the staff and the capacity in the community. I'm afraid I'm pretty sceptical. The funding envelope of that this SR period is now left, it works out at about 2.6% real terms growth that the NHS has. This is after we've made some adjustments for higher national insurance costs and some changes around pensions. So there isn't any headroom in that for the level of sort of double running of services and some element of duplication that I think is inevitable if we're talking about really quite radically changing the type of services that patients, the way patients interact with health services. So instead of going to the shiny hospital, or perhaps the not very shiny hospital these days, but the building in which people invest a lot of trust in and that they're used to going to, and they find it very reassuring to go and see a very medicalized model. That I think is a really crucial part of how we've traditionally experienced healthcare, and what the 10-year plan is trying to do is it's trying to demedicalize some of these pathways. You don't always need to see a consultant. You can see a nurse specialist, for example. But I think that in order to embed that and to gain patients' trust, that there is going to have to be some double running. I think a really unexplored area here is around patient acceptability of the type of services. If you want to avoid patients turning up at A&E or calling 999, to trust in these kind of community intervention teams, for example, for frail elderly, you're going to have to show them first that it works. So I think that in addition to just setting up new teams, and whilst you can't shut the hospital ward on Tuesday and reopen the capacity in the community at 8 a.m. on a Wednesday. So and it's frustrating. I mean, I understand the money is the money, so that is why there's almost a kind of pretending that that this can be done without some financial headroom. But I think we need to have a bit of realism about this. There isn't headroom. And there isn't clarity. It's like the other way we could go is, okay, there isn't headroom, so what does the NHS stop doing? To on the acute side, for example, that there isn't headroom there either, because we have an 18-week elective target, and I know we're going to come on to it and discuss it later on. But we are now going to have significantly higher costs in the new branded medicine side. So I'm afraid I am pretty sceptical.
That's great. Thanks, Sally. Move on to you maybe there, Richard, in terms of how smooth do you think the transition is going to be from acute to community settings?
Well, I think it's going to be really difficult to do, but equally, I think everybody recognises it's the transition we've got to pull off, and kind of everybody wants to make it happen. I've three quick reflections. I mean, 2 of our prototype neighbourhood health centres were recipients of some of the money announced in the budget, and obviously we're very kind of pleased about that. It will help us build stronger locality hubs and extending a model that we have started to see the benefits of, for bringing together community health services, general practice, social care and mental health services in a different kind of interface with the acute hospitals in our patch. So I don't want to kind of dismiss the effect that even relatively small amounts of funding can have in that context. I then I guess have two quick further reflections. The first is, I think there's still a bit of a battle for the soul of neighbourhood health going on between is this just about kind of redesigning NHS outpatients and moving some activity to a different kind of building with a different sort of label? Or is this genuinely about a different kind of partnership with communities, with social care colleagues, with people who understand kind of issues around helping people back into work and wider community regeneration? And I really hope we don't miss the opportunity to build that bigger, more preventative, more community-based approach. And I also really hope that work that's taking place, but possibly taking place kind of a bit behind the scenes, on how you resource increasing activity in the community as it happens in the kind of rules-based tariff-style world, is able to be accelerated and come to the fore. Because without that, all of those challenges around double running and how you take money out of one sector and put it into another will make this really difficult to do. And that feels like it's in the kind of middle part of the planning at the moment rather than the early part, and it probably needs to move forward.
That's great. Thanks, Richard. If we could go to you, Shane, just on that transition and how you expect it to impact your trust as well.
Yeah, I think it's interesting. 120 of these centres to be built by 2030. I'm normally pretty optimistic, but I think that's going to be tough going. And maybe I'm slightly stung by my own experience of trying to access NHS capital for things such as, say, Whipps Cross Hospital redevelopment, which of course I know the delays on that and the issues that has for local people, local communities and expectations. So I worry about that. I think Sally's point about the kind of transition is really a good one. This kind of myth that something is built over here and the next day, something closes over here and stuff just moves. I mean, patients don't think about your own experiences with healthcare yourself, or taking parents or children. You don't think like that. You think about, where can I access services? So there's going to have to be something here about how we work with patients, how people can understand these pathway changes if to be effective. And probably the last point I'd make is there's quite a debate going on in the hospital sector about, hospital bad, community good type of rhetoric. And a sense, of course, that if you spoke to constituents in my patch, say in Newham, they would definitely see Newham Hospital as part of the community. So there's a strange concept I think here we need to work through. But bottom line is, there's too much activity coming to the hospitals. Everyone accepts that. We have to work on this. I'm quite keen that we make this as orderly as possible and as easy for patients as possible to access the right services.
Great, thanks, Shane. Steve, would you like to comment on this?
I'll try and be brief. I mean, I always start with the exam question. There's no question Richard set that out. There is an exam question here that needs to be answered. Just yesterday, the NHS published data showing the rising number of people turning up at ED with, the Secretary of State was talking about hiccups and ingrowing toenails, right? So clearly the public are concerned and the public are confused, and they're therefore turning up in the wrong, inverted commas, place. But if you look at the 10-year plan, if you word cloud it, it's digital and it's access. They're the two words that I think would stand out for you. We've talked a bit about digital. We could talk about it, as you said, for half an hour. On access, which is what this really is about. That's the exam question this is seeking to answer. Richard puts it very well. What the battle for the soul? When they launched the 10-year plan, the Prime Minister went to a community diagnostics centre, which he called neighbourhood health centre, in Stratford in East London. There was lots of talk about neighbourhood health centres. Then it was neighbourhood health. Now it seems to be neighbourhood health centres again, which are a physical thing. They are a presence in the community. I don't think you can underestimate, in trying to create neighbourhood health centres, the standoff that's going on at the moment between the government and the GPs. The GPs are mega cross. They're mega cross about online access. They're super cross about the fact they say they didn't see a 10-year plan before it came out with all this stuff, neighbourhood health. And they think neighbourhood health should be built around them. Because if a neighbourhood health centre is what I think it is, what they said in the Labour manifesto, what it says in the 10-year plan, which is bringing services, quotes, under one roof, well, then sure, okay, let's bring community and primary services under one roof. But aren't they called GP surgeries? That's certainly the GP's view. Now, look, whatever your view is on whether GPs are being laggards, the Secretary of State's word on this or not, whatever your view on that, the fact is that is their view, that these neighbourhood health centres should be built around them. So I suspect what will happen is that instead of the best of the NHS, the rest of the NHS, I suspect that you will see good transformation in some areas. I suspect the Northeast will be good. I suspect Frimley will be good. 'Twas ever so. And you will see GP surgeries morphing into these neighbourhood health centres. You'll also see community diagnostic centres morphing into what they then call neighbourhood health centres. And one way or another, by hook or crook, they will get to the number that she set out in the budget, because that's how we politicians work. We try and hit our number so that we can't be accused of not hitting our number. They'll do it with 18 weeks as well. But whether they actually have the services in there that answer the exam question, I think, that is still a massive, massive unknown. And the thing about using private capital to do that, the new PFI, well, okay, but then it comes back to politics, doesn't it? Everything comes back to politics. Will the Labour backbenches really allow that to happen? I'm not so sure. If you go back to the 10-year plan, page 28, as we do more in the community, funded by a reduction in hospital share of total NHS expenditure. Well, if I was Shane, I would want to know, what did that mean? When does that mean? And how much exactly does it mean I get less in the next financial year when I've got to write my budget starting on April the 1st? These are all unanswered questions. The 10-year plan is fantastic. It's full of hope and it's full of ambition. Alan Milburn said to me, I think it's full of hope and clarity. I said, Alan, it's definitely full of hope. What it's missing is the deliverability. And that's because I don't think they have the answers to the questions that they've posed. And until they do, I think the NHS is going to muddle on, dealing with the day job, dealing with the industrial dispute, dealing with winter, which is where most of the NHS is rightly focused at the moment. And transformation, hey, I mean, that's just for another day. But whether another day comes, I really hope it does, because the exam question definitely needs answering.
That's great. Thanks, Steve. I'm conscious, obviously, we're rattling through this, time's advancing. What I want to get your views on, obviously, which is something that Sally's spoken a lot on, is the implications of the US trade deal. If we could just have a couple of quick thoughts from you. If you want to start with that one, Sally.
Yeah, we still haven't really got a huge amount of clarity on the details here, and in particular on the cost. So I think there's been a fair amount of confusion, partly driven by that slightly earlier than it planned publication of the OBR's report, which did contain a 3 billion figure. But actually, if you read that, the context of that figure, that wasn't actually certainly wasn't set out as if this is the cost of any deal, not least because the deal had not been signed off or announced at that point. That was actually presented as the base case increase in new branded medicine spend over the SR period. So we've had the Health Secretary talk about an expectation of around £1 billion of additional cost by 28 to 29, which triangulates with what I've been told from the Treasury. But what I think is fantastically unclear is which of the multiple moving parts does that relate to. So we have two main moving parts. So one is an increase in the NICE threshold, which I think is a disaster for anybody who would like to see the NHS maximise the health benefits it gets for its expenditure. I think that is really clear from multiple pieces of research led mainly by York University, who have a brilliant track record on this. So that is one of the moving parts, and the other moving part is obviously this very complicated rebate system around agreeing a growth rate in total expenditure on certain classes of drugs, and then the growth rate is capped, and then there's a rebate on expenditure that's over that. So we've got two moving parts, and what I don't think we have clarity on is whether or not the alluded to 1 billion extra cost relates to both those moving parts together or just one of those moving parts. But also, I think there's also some substantial uncertainty in terms of what is actually in the pipeline to come through for assessment by NICE. But I think the research and the track record is very clear that the £35,000 upper threshold, and to be clear, this is the upper threshold on kind of normal drugs. Obviously, there's a much higher threshold already for drugs that to treat rare diseases. This will become the new price point. So essentially the NHS is on a fairly short track to paying substantially higher prices for what it was getting anyway. So yeah, and it's very clear that this is at a very significant opportunity cost. Roughly, you'll get one quality adjusted life year benefit for £35,000, where you could be getting around about 3 times that amount if the money was spent instead on extending the services that the government says it wants to extend. The services in the community. In particular, GP services you get in GP practices, you get in community care. The evidence shows are vastly more cost effective than new branded medicines.
That's great. Thanks, Sally. Shane, can I go to you on that one?
Yeah, I mean, Sally's clearly far more knowledgeable than I am on this. I think I'd probably make just 2 points. I think one is that whilst the financial impact of the NHS is yet to be understood, at a time when we're trying to deliver really challenging and really difficult financial plans, clearly anything that's going to add risk to that is an additional pressure. So that'd be kind of a global thought. Interestingly, though, some parts of my team are positive about this, insofar that, as they understand it, kind of the trade deal will have a positive impact on kind of exports to the US, and therefore probably will help support the life sciences sector. I've got a huge life sciences development happening in Whitechapel and East London. So, and from sort of a London and a UK PLC perspective, that is positive. And I think we therefore want to make sure we can capitalise on that as much as we can.
Go to you next, Richard, on that one.
I mean, questions around kind of international trade deals are definitely above my pay grade, and I would defer to Sally. But I guess my reflection is that, the debate about kind of where we put scarce resources between, kind of expensive, sophisticated new drugs that treat, particular kinds of diseases in a particular way versus kind of longer term or lower cost preventative type interventions is a really difficult one, and perhaps particularly in the context of some of the pressure we face to get the right community support to children and young people, which is kind of often a neglected part of the debate. So it's a kind of judgment around priorities, isn't it? And the more we end up doing at the expensive, sophisticated end, the less chance maybe we've got to make some of those lower cost preventative measures, particularly for children and young people, stick in the way we're going to need to.
That's great. Thanks, Richard. And maybe I can finish with you, Steve. Is this a Trump shake-up of the NHS?
100%. I mean, look, Donald Trump was very clear that the America First policy was to extend into medicines, and that he felt that they were getting a bad deal. They probably were. But look, the VPAG deal that the last government signed, I don't suppose that my former colleagues will thank me for saying this, but was a disaster for the life sciences sector. And I think they shouldn't have signed it, and the ABPI shouldn't have signed it. The whole VPAG thing has been the great bore of Whitehall this year. Everybody is just absolutely eye-rolling about it, and they're so pleased that they think it's over. I don't think it is. I think it's been kicked actually a bit into the long grass, and I pick up from a lot of people very senior that they don't think this is a great deal. You're right, Shane. Your colleagues are right that UK origin pharma ingredients, medtech, exported to the US, 0% tariff. So yes, from a London, from a UK PLC point of view, they're absolutely spot on. And in exchange, we're then committed to spending about 25% more, which is where the £3 billion comes from, on new and effective treatments into frontline for British patients in the NHS. Whether the latter happens, the former, I think, will. Whether the latter happens is still a big question mark. And in terms of that £3 billion, I think the big unanswered question is who pays. It's a bit like the NHS redundancies thing. That has been they borrowed from Peter to pay Paul on that. That's been kicked into the next financial year, and then the one after that. And things don't get any easier when you kick debts down the line. So I don't know who pays. I'm not sure they do. But look, the life sciences sector they're happier than they were this time last week, but I think everyone's tired of this. It's Christmas. People just want to put it to one side and think that it's solved. But I think those of us that look into the weeds of this know that it isn't, and it will come back again.
That's great. Thank you, everyone. I think we'll probably have to leave it there. It's been a great discussion, and I'm looking forward to discussing these topics more fully in the new year. But thank you again for your time, and enjoy the rest of your day. Thank you.
Talk to you.
Bye.
Bye.